Welcome to St. Luke's Health Now, a show dedicated to giving you the most up-to-date information on cutting-edge medicine. I'm your host, Ashley Russo, and we have an exciting show for you tonight. We're talking about atrial fibrillation, also known as AFib, and the role of ablation, medication management, and overall heart health, with a panel of premier experts in this field. We're hearing patient stories of success and taking questions from our live studio audience. Stay tuned. This is St. Luke's Health Now. Coming up on this episode of Health Now, an in-depth look at atrial fibrillation with St. Luke's University Health Network. Stay tuned. Thanks for tuning in. Let's get started. We have an incredible panel of guests today on Health Now. Joining me first is Dr. Darren Traub, a cardiac electrophysiologist. A native of the Lehigh Valley, Dr. Traub specializes in the evaluation and treatment of cardiac rhythmic disturbances. On a daily basis, he performs pacemaker and defibrillator implantation and catheter ablations. Meet Dr. Traub.
My favorite part of my job is following up with patients in the office after they've had successful procedures and seeing the smiles on their faces because their life has changed. I specialize in diagnosing and treating heart rhythm disturbances. I was always fascinated by the heart, and the further I went along in my studies, the more and more I was drawn to cardiac care. And what I really enjoy about cardiac care is taking patients who come into the hospital very sick and then getting them better and seeing them as healthy outpatients.
Thank you so much for being here, Dr. Traub. This is a pretty complicated subject, so let's start with the basics. What is atrial fibrillation?
Atrial fibrillation is a heart rhythm disorder in which the top chambers of the heart begin beating chaotically and irregularly. When they beat chaotically and irregularly, they lose their normal contractile function. Blood pools, and this can predispose a patient for having a stroke.
Excellent. Thank you for that. We're going to meet your partners now so we can learn a little bit more about AFib.
Great.
Joining our panel next is Dr. Steve Stevens. As a cardiac electrophysiologist, he's an expert in heart rhythm disorders. Dr. Stevens performs complex cardiac catheter ablations as well as implants pacemakers, defibrillators, and cardiac resynchronization therapy devices to treat heart failure and prevent sudden death. Meet Dr. Stevens.
Here at St. Luke's, they really have created an environment where we can be very accessible to our patients. They have open communication with us, and I think that makes us more caring and develops a connection and bond with them to help them through their problems. I really enjoy what I do, and I genuinely think that what we do makes people better. The best part about what I do is seeing patients get better.
Dr. Stevens, thank you so much for being here.
Thank you, Ashley, for having me.
Dr. Traub talked a little bit about what AFib is, but can you tell us a little bit more about what the symptoms are and how somebody would even know that they're in AFib?
That's a great question. Atrial fibrillation is different to different people. So some people really can feel their heartbeat, and they might feel palpitations or an irregular heartbeat, and that might be what prompts them to go see a doctor. But what makes AFib scary is that some people don't feel it, and they may not know they have it, and those are the people we want to identify to help get on medications to prevent strokes.
It sounds like it's important to know the warning signs and get yourself checked out sooner rather than later.
Absolutely.
All right, let's meet your final colleague. Joining us now is Dr. Sudeep Nanda, also a cardiac electrophysiologist. He performs complex cardiac catheter ablations to treat AFib, supraventricular tachycardia, and ventricular tachycardia. Additionally, he performs lead extractions for pacemakers and other implantable devices. Meet Dr. Nanda.
When a patient has initially been extremely scared, then undergo a procedure, and then they come back, they're back into relatively normal life. That is always the best feeling. Newer developments are happening every day. The fact that you can change the rhythm of the heart by an ablation was something remarkable, and that's why I wanted to be in medicine. It is a very good realization to know that the end of your fellowship is really the beginning of your learning.
Doctors Traub and Stevens were telling us a little bit about what AFib is and what some of the symptoms are, but really, what can it do to a person? How can it hurt them, and why is it dangerous to leave untreated?
Well, AFib can be dangerous even if you don't treat it or while you are treating it. When you are not treating it, the biggest risk is risk of stroke. If the heart rate is allowed to run at a rate more than 100 for 2 to 3 months, the heart actually weakens and you'd start developing symptoms of heart failure. Finally, a lot of quality of life index studies have been done all over the world. Patients with AFib always fare much worse compared to patients in normal rhythm.
This is excellent information. Thank you all so much. We're going to dig a little deeper on this topic as we continue on with our show. Later, we'll have studio audience questions. Stay tuned. We'll be right back after a short break. You're watching St. Luke's Health Now.
I had gone for a colonoscopy test, and the Dr. Vazier said my pulse seemed to be irregular, and he recommended that I see a cardiologist. That's what I did. I went to see Dr. Dale, and Dr. Dale said that I had AFib. They said, okay, what we're going to do is we're going to go into the heart and stop the AFib. And so I'm still in rhythm, and so I'm very fortunate. They did a fantastic job, and I look at Nanda and I said, great. He said, hey, I'm totally impressed.
Welcome back, and thanks for watching St. Luke's Health Now. I'm Ashley Russo, and I'm joined by an outstanding panel of cardiac electrophysiologists, physicians Dr. Darren Traub, Dr. Steve Stevens, and Dr. Sudeep Nanda. They've walked us through some of the most important points relating to AFib. Thank you to our audience for being here today and providing us with such insightful questions. And to our patient participants whose stories you're hearing throughout the show, we thank you. Let's go into more depth and talk a little bit about AFib. Dr. Traub, what medications can help the management of AFib?
Well, there's two really important concepts to treating atrial fibrillation. First is to prevent a stroke, which my partners are going to talk about a little bit more in terms of what blood thinners are available. But the second thing is we need to control the patient's symptoms. And when it comes to controlling the patient's symptoms, we break that down into either rate control or rhythm control. In rate control, we say, we're just going to let your atrial fibrillation happen, but we're going to slow your heart rate down with drugs called AV nodal blocking agents. And those drugs basically just slow traffic down in the heart. Rhythm control, when we take that approach, we say, well, the patient is so symptomatic that we can't allow them to be in atrial fibrillation. And then we give them drugs called antiarrhythmic agents that are designed to keep the heart in regular rhythm. If those drugs don't work, we'll often move on to ablation therapy, where we actually go into the heart with catheters and cauterize the area where the atrial fibrillation is coming from.
How difficult is it to figure out where the patient is in the disease process and how to treat them? Dr. Stevens?
It depends. So early in the process, we often, most importantly, get the patient on some type of blood thinner if we think their risk of stroke is high, because that's really the most morbid thing that could happen to you. And so if we could do that, and we've done our job. The next thing is to figure out if the AFib is contributing to a cardiomyopathy or heart failure. Is it making their heart sick? And then we tend to be more aggressive with treatment in that situation. If they're their heart's healthy, they're not very symptomatic, and they're on blood thinners, usually that's a good place where we're satisfied with their treatment. But treatment meets the challenge of the patient. If the patient's not feeling well, they're short of breath, they're having a lot of palpitations, we're going to treat them more aggressively. And so we have to find out where they fit in that spectrum.
You both mentioned stroke as really your main concern when you see a patient. Dr. Nanda, can you tell us a little bit about the medications that are available and how you would kind of prevent stroke from happening in an AFib patient?
So the medication that has been used for almost 50 years is Coumadin or warfarin. It's a blood thinner. Its predominant action is to prevent clot formation. Important to know that the clot that forms and results in heart attack, that's a platelet-rich clot, whereas a clot that forms in AFib is a little different. So an aspirin which is used so commonly for heart attack patients is really not that useful in atrial fibrillation. It takes a long time, about 2 to 3 days, to be effective, and also a long time for its effect to wane off. This led to development of other agents. But very important to remember, most people are not therapeutic in that range of 2 to 3 for a majority of the time. The entire concept of time in therapeutic range, TTR, was developed for that. If you are in the therapeutic range for about 70% of the time, you are protected.
It sounds like you really need a very personalized medicine approach because every patient is different and the complexity of their case really determines what direction you take. There have been a lot of commercials about some of these new stroke medicines that are out there that are, talking about lawsuits. Can you tell us a little bit about the concerns and what you're hearing from patients in regards to that?
Sure. Well, in 2010, the first what we call novel oral anticoagulant came out. And given that they're now 6 years old, I think we can almost eliminate the term novel. But they're now the most prescribed blood thinner. And unlike warfarin, where these agents can be affected by food and by drugs that you take, for the most part, they're actually very clean agents. In other words, you just take them once or twice a day. You don't need to go for blood tests. And they have much less drug-drug and drug-food interactions. So although people will see commercials saying that these agents aren't safe, actually in tens of thousands to hundreds of thousands of patient studies, studies involving patients taking these medications, these agents have proven to be just as safe, if not safer than Coumadin, and just as effective. So I think that the lawyers have done patients a little bit of disservice by advertising that these agents are unsafe, because actually in clinical trials and now in real-world data, they've proven to be very safe and very effective.
What about when you need to reverse a blood thinner? I mean, what do you do about that, Dr. Stevens?
That's a great question. So warfarin is a vitamin K antagonist, and so what that means is that it blocks a pathway in your body where vitamin K is metabolized, and that's what makes your blood thinner. So you give vitamin K in that case, but it actually takes hours to reverse. And so if you had a motor vehicle accident, you were bleeding, you don't have hours, you've got to do it really quick. So we actually give blood products that help the blood clot more. We do the same thing for the newer agents. So when we say they don't have a reversing agent, what we're talking about is vitamin K. But it turns out that this year, all of them are coming out with their own reversing agent. And one of them is already available, Praxibine, which reverses Pradaxa, which we've been prescribing, actually used in an operating room setting, and it actually worked fantastic. And it's like the patient wasn't on a blood thinner at all. So I think the days of not having reversing agents are really over.
I would think that that would be very helpful information for patients on blood thinners to know that especially in an emergency situation, there are drugs out there that can reverse those blood thinners and get them healed and, well very quickly.
Absolutely.
Well, this has been great information from our panelists, but we are not done yet. After the break, we'll find out what ablation is and when it's the appropriate course of action. You're watching St. Luke's Health Now.
Well, I was 16 years old and I was playing basketball and I started to feel that something was wrong. I went to the doctor and they said, you can't play basketball anymore. It's super dangerous and we need to replace parts of your heart. The layman side of it is they burn little areas of your heart to stop electricity from going to places it shouldn't. And my heart was crazy with electricity going places it shouldn't. You can't really foresee the future. You don't know how it's going to play out. So you trust in the people that you fall asleep under that are going to be working on you, that when you wake up, the problem will be solved. Thanks to St. Luke's, I'm playing basketball again and really enjoying it.
Welcome back to St. Luke's Health Now, a show dedicated to giving you the most up-to-date information on cutting-edge medicine. I'm your host, Ashley Russo, and we have an exciting show tonight. We're talking about atrial fibrillation with a panel of amazing experts. We're hearing patient stories of success and taking questions from our live studio audience. In case you're just tuning in, our panel consists of 3 cardiac electrophysiologists from St. Luke's University Health Network, Dr. Darren Traub, Dr. Steve Stevens, and Dr. Sudeep Nanda. Thank you all for being here. We've had a great, robust discussion laying the groundwork for some of the things people need to know about AFib, and we've talked a little bit about medication management. But what about other treatments that are available? Dr. Nanda, can you tell me a little bit about what AFib ablation is?
The concept of atrial fibrillation ablation started in France by Dr. Heiseger from Bordeaux. What they found is almost 85 to 90%. It is the 4 or 5 pulmonary veins draining into the left side which initiate it. And they found that if they could electrically isolate it, meaning create a series of lesions which would electrically disconnect the vein from the atria, atrial fibrillation will stop. So entire concept of ablation is the veins will remain attached to your atria. They will still bring back blood, but electrically you create a ring of scar which does not allow the muscle potential to enter your heart and put your heart into abnormal rhythm.
Dr. Stevens, do ablations really work?
It's a great question. So I always tell patients we can't cure AFib. It's not curable, but we can suppress the heck out of it. And that's what ablation really does. When we do the ablation, it makes AFib happen less often and for shorter duration. And so if you look at the studies, you'll see, oh, well, ablation for persistent AFib, that's people who are in AFib every day all the time, only works 50% of the time. But the majority of my patients actually are in sinus rhythm. Is it because I've done well? And it's actually because of the way you track data. If you look at those patients that have recurred, they may have recurred for only an hour or two, but for them it really does work because now they're not in AFib very often and they feel much better. So the efficacy can be terrific for a lot of patients. But it is common to need 2 ablations throughout a lifetime. So we quote about 1 in 5 patients need 2 ablations, and it actually works a little better the second time you do it. So it's a lifelong process of treating these patients.
I would think that instead of thinking of it as being cured, you think about it as quality of life and the improvement that can be made from something like ablation.
Absolutely, absolutely.
So now that we have an understanding of what AFib ablation is, are there different kinds of ablation that can be used, and what are the risk factors associated with those different types?
In terms of atrial fibrillation ablation, the basic concept is to electrically isolate the pulmonary veins from the left atrium. There's 2 ways to do that. You can do a catheter ablation, which was the first type of ablation done, and in that procedure we take a very small catheter, it's 3.5 millimeters, and we drag it around the pulmonary veins to create a lesion set that eliminates their electrical activity from the left atrium. Now there's something called the cryoballoon ablation, and that's actually our preferred treatment at St. Luke's University Health Network. The advantage of the cryoballoon ablation is that you literally blow up a balloon and park it right in the entrance of the pulmonary vein, and you can freeze that tissue all at once. So you create almost a perfect circular lesion set that in one go eliminates the electricity from the pulmonary vein. So the cryoballoon has just made the ablation procedure simpler, it's made it faster, and patients seem to tolerate it better. In head-to-head trials, there was really no demonstrable difference in outcomes, but overall we feel that the cryoballoon as certainly a first-line procedure is the way to go.
Regardless of whether you're talking about using the catheter or using the cryoballoon, I'm really hearing you're using electricity in some capacity, and that sounds scary. So is this safe? Is this something that, as someone who may not understand, really the medicine behind it, is this something that you should be concerned about trying, or is it something that's pretty run-of-the-mill?
That's a great question. My patient's safety is the most important thing to me, and so I wouldn't do the procedure if I thought it was unsafe. But every procedure you do in medicine has a chance for complications, and this is a procedure on your heart, so we do it very carefully, and we've done a lot of training to do it skillfully, but you can have complications. The complication rate is 4%. Very serious complications are rare. The most worrisome complications obviously would be death. It's fortunately much less than 1 in 1,000, and if it were higher than that, we'd have a hard time getting up in the morning to do this procedure. The fortunate thing is most of the complications we deal with are actually pretty minor. Bleeding in the groin, patients might have some post-operative discomfort in their chest, shortness of breath, but most patients actually go home the next day feeling pretty good, and the recovery is quick.
What if ablation doesn't work, Dr. Nanda, and Then what are patients' options?
Depending upon what the source of the ablation is. So first thing I would say is immediately post ablation, the heart is irritated. Think of it, you are either burning or freezing. So for first 3 months, patients can be given medications to see how it goes. For many, the abnormal rhythm settles down. For others though, you can have an abnormal rhythm which comes back. Then you have a discussion with your patient of what you intend to do. Sometimes, since you have isolated a lot of the veins, medications which were not useful become useful. So you can put them on rhythm control medication.
What about patients who are too frail or ablations have failed? You sort of started to mention that, Dr. Nanda. Dr. Traub, what are some options for those patients?
Well, when I talk to a patient about their atrial fibrillation, I always have a plan A, B, C, and D. So I like to say to them, we're always going to have something to make you feel better. So let's say a catheter ablation doesn't work, or cryoablation. We might do a more extensive surgical ablation. And then the other option for people who really are sensitive to the irregularity of the heartbeat, we can put a pacemaker in and we can cauterize or ablate the connection between the top and bottom chamber of the heart, and we can let the pacemaker take over the heart's rhythm. And that sounds scary to a lot of people, but pacemakers are about 99.999% reliable, and they will make the heartbeat completely regular. And that can be a real wonderful treatment for patients who have failed ablation, or maybe who are too frail and elderly to go through a normal atrial fibrillation catheter ablation.
Thank you all so much. Great information, very informative and in-depth. Up next, questions from our live studio audience. Stick with us. You're watching St. Luke's Health Now. Welcome back to St. Luke's Health Now. I'm your host, Ashley Russo. A special thank you to all of our audience members here today, but especially to our patients for sharing their stories with us. And of course to our wonderful panel, Dr. Darren Traub, Dr. Steve Stevens, and Dr. Sudeep Nanda. All right, we've got some questions from our studio audience. Let's get started. First question, would AFib cause the feeling of shortness of breath?
Atrial fibrillation could cause shortness of breath in two ways. One, when your heart's fast, you might just feel short of breath. Two, if your heart's been fast for a long time, the muscles become weak and you go into cardiomyopathy or congestive heart failure, which makes you short of breath. So the answer is yes. If you're feeling short of breath, you should be evaluated by a doctor. AFib is on the differential or many types of things that cause shortness of breath. It's one of them.
Right, so shortness of breath, see a doctor. There are a lot of things that can cause that.
Yeah.
Next question, what about using shock treatment? Is that still a viable option?
So what the question is, you are in AFib, you go to the hospital, you get shocked, and you go home, and it comes back. It will usually come back more than 70% of the time. This is something very commonly done, and I think it needs to change. If a patient is needing cardioversion for AFib, patient should be on some kind of antiarrhythmic. Decision needs to be made early than late.
So don't just rely on the shock treatment and think things will get better.
Definitely see your cardiologist, if needed your EP. The earlier, what we get to say is patient has been cardioverted for 2 years and now the cardioversion does not work even a day, and that's when they're coming to us. Instead, the treatment of AFib is you delay it. You cannot stop it. Start your antiarrhythmic early so that it's delayed. You don't get repeated shocks, you get recurrence, then you go think about ablation.
Here's a fairly specific question. Does having TIA symptoms and surgery to clear a carotid artery raise the risk of AFib, or is it the other way around? Dr. Traub?
Well, if you have carotid artery disease, you are probably more at risk for having atrial fibrillation because carotid artery disease is associated with other AFib risk factors such as diabetes, hypertension, being older. But also, if you've had a transient ischemic attack, or mini stroke as we like to call them, you might have undocumented or undiscovered atrial fibrillation. And in that case, we often put a little jump drive under the skin called a link. We have a picture of that, or an example of it. And this little device actually has a 3-year battery life and is sophisticated enough to detect atrial fibrillation and then transmit it via Bluetooth to a monitor and tell our office that you have atrial fibrillation. So
that is amazing. That is really amazing thing. So you can get that put in, and for 3 years, You're in constant contact with your office?
That's correct. We like to say we're watching you.
That's for sure. Another question here from our audience is about the world's smallest pacemaker that St. Luke's carries. Can you tell me about that, Dr. Nanda?
One of the commonest indication for device is in patients with atrial fibrillation, where the heart rate is very slow. We have traditionally used devices which have a single lead implanted in the ventricle. It's a device and a lead separate. Most of the complications related to the device is because of the lead. This newly developed device, and this is what a pacemaker would look like, this new pacemaker is this.
Look at the size difference. So you're holding on the left.
This is your without
the
leadless
new-
pacemaker, and this is your usual pacemaker. What it does is it's embedded directly inside the heart, and it can take control of your heartbeat. Advantage is there's no lead, so no lead related complication. Second, you are back to whatever you do immediately, no restrictions as we put on people who have a new device placed, new leads placed. And it is well enough that it lasts for 10 to 12 years also.
That is really an amazing progression to see the size difference of those two devices. Another question we have from our studio audience is how long does it take for Pradaxa to go into effect once one takes it?
The nice thing about an agent like Pradaxa, and there's other ones, Eliquis, Xarelto, is that as soon as you metabolize them, they're fully effective. So half hour to an hour, your blood is fully thin, whereas warfarin actually takes 5 days to build up. So patients are unprotected during those first 5 days of warfarin or Coumadin, whereas Pradaxa, they're immediately effective, that's an advantage to that drug.
Excellent. Well, thank you so much, all of you, for being here. Thank you so much for our studio audience for providing our questions this evening. We've learned so much about AFib. It sounds like it's important for us to get to the doctor if we're feeling any of these symptoms and make sure that you get a personalized medicine plan to make sure that you're treating AFib exactly for what's right for you. Thank you all for being here this evening. For more information on AFib or cardiac care at St. Luke's University Health Network, please visit their website at sluhn.org or call InfoLink at 1-866-ST. Luke's. I'm Ashley Russo. This is St. Luke's Health Now. Thanks for tuning in. Until next time, be well and remember it's important to focus on your health now.